I wanted to welcome everyone tonight. We are joined here by Dr. Gavin Ripp. He is the Chief Operations Officer of Balance Health. We are also joined by Dr. Jonathan Moore. He is a podiatrist from the California School of Podiatry, founder and former managing partner of Cumberland Foot and Ankle Centers of Kentucky, the inventor of the Moore Balance Brace. So thank you both for joining us today. We're excited to talk to you all about fall risk and how you are managing that within your practices. So, Dr. Moore, tell us a little bit about your practice and how you approach fall risk.
I think we all know that there are some doctors in podiatric medicine that are doing fall risk assessments. I think that should be stated very clearly. In fact, I think Balance Health has been a leader in that regard with respect to really trying to implement the use of a objective and strong fall risk assessment tool like Safe Balance. So I guess it's important to state that I know some are using it, but I think we're all here to talk today about the fact that we may be underutilizing the service. And what I try to do in my clinic, Danielle, is try to follow an algorithm of treatment based upon my assessment that's built into the test. So Safe Balance allows us to look at a lot of different things, including them just simply walking, answering certain questions, the history of falling, all those things. And that's my responsibility to put a plan in place. So for many years in my practice, being in Kentucky and in the southern Kentucky area, we see a lot of geriatric patients. So I think what's important for us is to identify these patients early. And that's what we try to do. And having this tool available to us allows us to do that.
Well, thank you. And Dr. Ripp, you are leading the charge amongst your Balance Health peers and colleagues and pushing fall risk management. How are you utilizing it currently in your practice?
One of the things that we always talk about as podiatrists is comprehensive care. We would be absolutely not providing the best comprehensive care for our patients if we did not look at their overall balance and their ability to walk. If you read the studies, podiatrists plays a huge part in improving the balance and improving the ability of our geriatric population to really maintain their independency. That's where it's really important to me. I mean, if you ask our elderly population, what do you want? Most people say, I want to be with my family and I want to maintain my independence. And really what we're doing as podiatrists when we're doing these studies is we're actually helping them fulfill their goals. We're allowing them to be with their family. We're allowing them to maintain their independence. And we're also decreasing the cost of healthcare at the same time by providing and being proactive.
Yeah, we agree. So, Dr. Moore, you've been using Safe Balance with us for a couple of years now. How do you utilize the assessment in your practice, and what do you do with that data?
The Safe Balance is beautiful because it's so simple and it allows you to get through it quickly. But unless there's some type of analysis of the report and some kind of action plan, it becomes really fruitless. And so I love what Dr. Ripp said when it comes to comprehensiveness, and that is not only a quality of care, but the standard of care. I still think that for some in our profession, the light hasn't come on with respect to these elderly patients coming in that clearly have abnormal gait and have clear and obvious fall risk factors, lower extremity fall risk factors. We still, unfortunately, are sometimes ignoring those cases. And this is the beauty of the technology that we have. We have these tablets that allow me to walk into the patient's room and say, Mrs. Jones, we just did a fall risk assessment. Here are the results. I think we need to do something. And Dr. Ripp said it beautifully. What do these patients want? They want to remain independent. They don't want to fall. They're terribly fearful of falling. We need to use those clear desires of our patient to present to them their risk. If we walk in the room and don't in any way infer that there's risk, there's not going to be a change in their behavior. There's not going to be an acceptance of a treatment plan. The reason why we've been successful is because we know what the patients need to hear to accept the fact that they are at risk and their willingness, of course, to do something about it.
Absolutely. How do you think the Safe Balance program, the initial assessment part, and the results that it gives you compares to the generalized MIPS questions that are being asked everywhere?
So I think the big difference between the questions they're getting at their primary care doctor's offices, usually those are coming from medical assistants, staff, nurses, and then there's oftentimes little done after that. I think the patients need to realize that this is something different. And I think the best way to do that is to take 2 minutes and watch the patients walk, watch them get up from their chair, take a few steps, because you're going to be able to ascertain a timed up and go immediately and that's part of the test that I think is the most integral for us, is assessing and at least characterizing their gait. And we can do that by documenting and characterizing their gait in the system. But also the timed up and go test is one of the most critical components of identifying risk in patients, that it's easy. These patients are going to either pass or fail it. So watching the patients walk and then asking them those questions, and the doctors being involved, I think that's the key to differentiating this, is the doctors taking that pad after, again, the staff is going to gather a lot of the information. I'm not saying the staff can't be involved, but if the staff constitutes the entire test and there's no one going in with the iPad saying, I just reviewed the results of your test and here's what it is and here's what it means, nothing really clinically is going to happen after that.
Yeah, I think to his point, when you ask the question about most of the MIPS questionnaires is just the STEADI questionnaire, which is the CDC questionnaire about have you fallen and the different things. And I liken that to, I have a 9-year-old and I asked him the other day, did you clean your room? And he told me yes. Right. Well, if I was to go upstairs and actually look in his room, you got crap all over the place, throwing stuff under his bed. He's got crap flowing out of the drawers and he moved one Lego to the other spot. But he could have just told me that he cleaned his room and I would have believed him. But when he go check, it didn't. And that's really what the STEADI questionnaire is. And then when you actually put them into the test and the timed up and go test, can they stand on one leg? Are you looking at any deformities that they have? Well, now you're actually checking the validity. Do they actually have a functional deficit that leads to falls? We actually print off the reports, and I actually give the patient their printed report of their fall risk. I talk about them, what the score is. I talk about the therapeutic recommendation or the plan in place to try to improve it. And then we discuss the next treatments and actually give it to them to go home with. So they can never say that Dr. Ripp never discussed my falls with me, because they have it with them. They're going home with it. And to me, it's an extremely important part.
How does this compare with other protocols that you have, like diabetic, foot care, wound care, things like that?
The Diabetic Association just updated that every person with diabetes needs to have an evaluation by a podiatrist once a year. It's in their official recommendation, just published beginning of this month. Why? Our job is to catch problems before they occur, right? Do they have a callus on the bottom of their foot? Well, that callus is a pre-ulcerative lesion. What are we going to do about it? Are we going to modify it? Are we going to offload it? Are we going to give them diabetic shoes? Are we going to give them inserts? Are we going to maybe even have to do surgery to reduce the deformity so that they don't have an ulcer in the future? To me, the way that we treat diabetics and the way that we're trying to be proactive to prevent problems from happening, the last thing we want to be is reactive. When we're reactive to a diabetic complication, a lot of times that's an amputation, or a lot of times that's significant healthcare dollars and a lot of treatment to get that ulcer healed. That fall risk is the same thing. We're being proactive. I think the fall risk is the leading cause of death in individuals 65 years and older. If you look at the cost for the hospitalizations related to hip fractures, less than 10% actually go back to living independently after these hip fractures over a certain age population. So what we're trying to do is prevent and try to be proactive in reducing these complications associated with falls so that we can improve their life and decrease the cost of healthcare, decrease the cost of hospital, decrease the time or decrease the hospital stays. And all this does is just good patient care. And it's exactly parallel to what we do with diabetics. It's the same thing. I can't tell you how many of my doctors say, doctor, I don't have time to do the fall risk. Well, but they have time to clip toenails that pay $38. And you're telling me you don't have time to do fall risk, when fall risk affects way more of the individual in their body than doing toenails. And so when we're looking at this and we ask about how can we improve patients' quality of lives, how can we reduce the cost of healthcare, and how can we provide a good service, fall risk is absolutely paramount in this conversation.
When you look at risk factors for falling, there's many risk factors, dozens. And what we're focused in on are the lower extremity risk factors that we're seeing. And we've mentioned quite a few. The presence of neuropathy dramatically increases the risk of falls. Like someone who has neuropathy versus someone who doesn't, 11 times more likely to fall. Foot deformity, lack of range of motion, those classic cases are well documented as being high risk factors for falling. But the number one risk for falling is muscle weakness and abnormal gait. And those are things that we see and focus in on. And so we have to think about, okay, well, these are things I'm registering. I see it. What do I do about it? I think what we need to talk about and get doctors thinking about is, what tools do I have available to me to put in place to address these modifiable risk factors?
Dr. Ripp, when you do find a patient who you have identified as a significant fall risk, What is your first step in treatment, in the treatment algorithm you use?
Physical therapy, silver sneakers, muscle strengthening, core strengthening is a huge important part of them improving their balance. So one of the things that a lot of patients with Medicare don't realize, there's a program called Silver Sneakers. And Silver Sneakers is actually a program that they can sign up to get gym memberships to fitness classes to improve their strength. That's catered to individuals specifically for weakness and balance. So we discuss Silver Sneakers. I refer them to my physical therapy colleagues. I'm one of those that when they have a failed test, I reappoint them 3 months later after treatment so that I can retest them. Have we made progress?
How do you get your patients on board with some of these things like physical therapy, like silver sneakers? How do you discuss that and make it relevant and make them want to be compliant with some of these activities?
It's all about presentation. What there has to be in place in order to get the patient to say, yes, I'm willing to comply, is you have to convey that if they don't do something based upon this test, their likelihood of falling and ending up in a nursing home and being one of these statistics, 1 in 4 seniors fall every year. 36,000 people die every year from a fall. There has to be confidence. There has to be a script. In fact, you've been in the room many times, Danielle, when I've walked in and conveyed this to patients, and I do this not in a scaring way, but I do it in a way that's compassionate. I don't want to see you fall again. I don't want to see you fall for the first time. And that's what many patients say, is they'll say, but I've never fallen. I'll ask them this. I'll say, for those people who say I've never fallen, I say, well, do you want to wait until you've fallen and broken your hip to start doing something about your risk? We don't want to wait until you've ended up with 3 surgeries before we start doing something. Let's do something now so that you don't end up in that situation. You have to be convincing, and you have to convey to the patient that if they do nothing, their likelihood of falling is really high.
When we are speaking to the podiatrist, what is door number 1? You don't do a fall risk assessment versus door number 2, you do.
I think it's a comfort level. So I think a lot of patients, they don't ever look at door number 1 because they don't look for the diagnosis. We have a lot of doctors in our organization. And I'm just going to use an example. They come in, patients want nail care. So they just clip their toenails and they get them out the door as fast as they can. But what they didn't see were the calluses on the tips of the toes, where tenotomies could come into play to relieve a pre-ulcerative condition. What they didn't see was the mole on the foot that could be a precancerous lesion that may need a biopsy. What they didn't see was the restricted ankle joint range of motion that decreases their gait, that they could benefit from an AFO. So they're not looking at all these things, and they're not thinking comprehensively. So it's, that I think it's just, you have that mentality, I'm going to take care of the patient or I'm going to take care of the foot. And it's not the same thing. When we signed up to be doctors, we signed up to take care of patients who are treating the feet, but we're treating the patients first. So when we talk about door number 2 is open for those doctors that see the foot's actually attached to a body, and we're going to treat the patient by way of the feet, right? That's door number 2, is let's treat the whole individual.
The problem is that if it's not made easy, the doctors are going to take the path of least resistance. Running a clinic with 20-something doctors for years, I've seen that. And that is to get through the day, get the nails done, and move on, even though we're leaving not only, the quality of care behind, but we're also leaving massive revenue opportunities that are being left on the table. So what's the solution? The solution is this. We need to have a protocol. I'm talking about the staff, the checkout. I'm talking about the nurses. I'm talking about all those things. All of those people have to be on board with this protocol. It can't be done in isolation. But when it works, and when you make it easy for the doctors to institute change or institute a plan, then it flies. But if the doctors are constantly facing difficulties and challenges in implementing a plan, it's not going to happen. It's going to happen inconsistently at best, and it's going to be difficult.
Yeah, I want to interject because obviously we all want to know what his protocol is, right? I want to know his protocol. I'm gonna write it down actually as he's talking about his protocol. That's what I'm going to do. But it's interesting. He talked about the standard of care, right? The standard of care is basically what we're judged upon as doctors. I was on a call recently with a doctor who wants to do well, but it wasn't doing a lot of things. Someone asked him the question, do you want to be average? Do you want to treat patients in an average way? Do you want to provide average care? Do you want to have average results? And so, to what Jonathan was saying, like not doing the fall risk, you're now even below average, right? You're not even meeting the standard of care. And so I would say to those listening, do we want to be average? Do we want our patients to have average results? No, we want to exceed the average. We want to be the best in our area. We want to be patients just absolutely glowing about the treatments that we offer and the prevention that we gave them. This is above average. This is taking it to the next step. This is going above and beyond to deliver comprehensive care.
I don't think anyone, I think some people are willing maybe to be average, but they certainly don't want to have an average income. And people who are lethargic and are taking the path of least resistance that expect to have checks that are exceptional, it's not going to happen. I think that to be pragmatic here, we're in a business and we operate a business, and doing nothing generates no revenue. And so we're looking to treat these patients and address their risk factors. But I think what will become very clear is that when you do that and do that effectively and consistently, your revenues aren't going to look average. Your revenues are going to look better than average, exceptional.
In this environment, patients are looking for doctors who can address multiple issues that they're having, even when they don't quite know why they're having it or that they do have it yet. And that is your job as the podiatrist, as the forefront in fall prevention. You guys are the ones who see the lower extremity issues the most frequently. You have the ability to make the most impact on these patients. Dr. Moore, we would love to hear your protocol and how you are utilizing this.
What I would like to propose is really something easy to remember. There's an acronym that you could use. It's BRIDGE, BRIDGE. And so I'll start with B, and that obviously has to be a balance assessment. So you can't implement change. You can't do anything without doing an assessment. And the Safe Balance tool is so easy, and it's a great way to begin change. And then we have to obviously report the findings to the patient. If that step is lost, you can forget the rest of the whole protocol. So there has to be a reporting of the findings. For some, it's easy to print that out. And when you can, that's great. I love to send those to doctors, and that's wonderful. But there has to be that step. And then there needs to be obviously the step of identifying to the patient why you're talking to them and what's happening. And the way I usually phrase that is, Mrs. Jones, we did this fall risk assessment. We've watched you walk. I've seen the strength in your legs. And Mrs. Jones, I know you've fallen before. I know you have issues. What I would like to do is do something to address those things, to improve your balance, to improve your walking, and reduce your risk of falling. And we have a plan to do that. And our plan involves getting you stronger. It involves putting something in your shoe to help improve your walking, improve your balance, improve your stability. And it's also going to be us checking your home and doing some things and giving you some tools to be safer at home. So where all this has to kind of predicate from is you need to help the patient understand that even though they may be falling or having instability as a result of vertigo or something that's like back pain or something that they maybe perceive isn't related to the lower extremity. What I have to do sometimes is say, Mrs. Jones, even though you're imbalanced and you're unsteady on your feet for a lot of reasons, the basis of my treatment is going to be basically to help improve your root system. And usually what I do is I use the same analogy. I say, Mrs. Jones, how does a tree stand up in the midst of a storm? It's by its roots. And the same is true for you. So what my goal is to improve the stability and support and structure around your root system, which are your feet. I want to stabilize them. I want to improve your walking. And we're going to do that by implementing a tool. And again, I'm not using initially the word brace. I want to use a tool to put in your shoe to help improve your walking and improve stability of your body. And the way we're going to do that, Mrs. Jones, is that we're going to use this. And I have a picture. I have a poster on my wall. I say, we're going to follow this plan. And the plan involves PT, the more balance brace, and it involves, of course, a shoe. Those three things are enough the first visit. So what I want to do, Mrs. Jones, I want to improve the stability around your extremities, around your feet. And we're going to do that through a lightweight support that goes in your shoe. I want to help you get the right shoe because your shoe is fundamentally important for your balance. And then I want to do some things either at your home or in any way we can to improve the strength and stability around your feet and ankles. If they don't seem to understand why you're focused on their extremities, again, explain it in a simple way that we need to improve their foundation. We need to improve the stability around their feet because when they begin to fall, what is it that keeps us upright? It's our feet and ankles. It's that postural stability. And this is the reason why I think having either the balance brace itself or having a poster with the balance brace illustrated on the wall. I think it's important to validate what you're saying, that this is something you do often. If it sounds like this is something you do randomly, they're going to be less convinced that they want to try this. And then what we do is I give them some educational material about the brace and about what we're trying to do with the brace. And that can be given along with the report of the balance assessment. And then what we do on that visit is we appoint them to follow back up to have their feet and ankles scanned for the AFO. Now, are there cases in which those can be done the same day? That's ideal. But in our setting, the flow of the practice, we schedule most of those. There may be someone in that clinic that's a floater that can walk right in and scan. I walk in, I do this quick presentation. I give them the information. I said, Mrs. Jones, I want to make you an appointment to come in where we can professionally take an impression of your feet and ankles to make these devices. And 99% of them say, yes, sign me up. I'll be happy to come back in. Or yes, I'd be willing to try this. And so that is what we do at that particular point. The patients will either come back in and be scanned. In the case that you have someone in the clinic that can come in quickly and scan, they're the ones doing or checking, of course, same and similar. And that person also is always going to be the one to make sure all the documentation is in place. And they are going to be the ones that are in charge of measuring and making sure a shoe is in place. So that does not take 20 minutes. It takes doing the test, walking in, Mrs. Jones, I've identified you're at risk. Here's our plan. It's really important, I think, to have that plan in writing or have it somewhere on your wall where the patients see you're not just making it up. And then the patients can see it, they understand it. And all I tell them, I said, Mrs. Jones, I want you to try this. I've done it thousands of times and it works really well. If for whatever reason, Mrs. Jones, this doesn't work for you, no one's going to make you wear these. No one's going to make you do anything. The goal of this is to help you walk better and be more balanced, be less unsteady when you walk. And so that's the objective. And so the patients usually always come back in to get scanned. We have a day for that set. I don't ever make the patients wait 2 weeks. Usually it's a matter of a few days. Sometimes our person that does this, and we have a podorthist that does this, the person that does this is there the next day. So sometimes the patients are coming in the next day. Sometimes I see those patients on a day he's there and they're scanned the same day. But usually the patients are scheduled. And then, of course, the order goes out. The person that's doing the scanning is making sure that the notes reflect what needs to be reflected. They're working with our billing people and the scans go out immediately. And so that process happens very fast, very quick. It does not slow the doctor down. But again, it takes some practice with what to tell the patients, and it takes organization of the clinic to get these patients scanned, to get shoes in play. And if the patients, of course, need therapy, most of the time we're writing it for it to be in the home, but that can be done a variety of different ways. So you can see that, of course, the protocol includes follow-up and all those types of things as well, but the protocol has to include a shoe, a brace, education, and then some type of documentation that you have recommended or that you're putting in place measures to improve strength and stability.
I love what you said. The one thing I would say is taking a step back, right? And I'm thinking about, all right, if I'm a podiatrist that wants to start doing this and starts doing the AFO and the scanning, I'm thinking about, all right, if I'm in those shoes, how do I do it? You know, John, you've been doing this for a long time. You got a well-oiled machine. You got your staff's got it down. I have found that in my own clinic and then in other clinics, if you're not comfortable having that discussion on the same day or doing the scanning on the same day, I would actually recommend that you reappoint the patient specifically for the fall risk discussion and scanning.
Yeah.
And what I have found, the conversion rate is actually much higher because you're spending the time talking specifically about their falls and they're improving in their balance. And so I think if you're in that clinic that's got the well-oiled machine, you do it the same day. And I do that in some ways because I've been doing this for a while and that's nice. In some of my clinics that we're introducing this concept to, I highly encourage those doctors, reschedule them back purely with the intent that this is what we're doing. We're going to have that conversation and we're going to scan them. And by the way, get the authorization for that brace before they come in on the next visit. Get that same and similar check before they come in on the next visit so that if you want to move forward with the more balanced braces at that visit, there's no barriers, there's nothing in its way. And you can just move forward knowing that you're going to be okay and you're going to go ahead and get paid.
In our training, AFOs are non-existent. So a lot of doctors are coming out. A lot of doctors are in practice right now that have little to no experience with bracing.
As much as it sounds crazy and as to the skeptic out there, that's like, this guy is full of crap, give it a shot. You will be shocked at the difference it makes in our patients' lives for their improvement in their balance. Some data, it's been shown to reduce the risk of falls by 60%. There's data backing the technology of these devices to improve their balance. And I would say, give it a shot. I was a skeptic once. I'm not a skeptic more. I have a large group. I recommend it to all of my doctors that I work with across the country because I know the difference it makes in our patients' lives.
But I will tell you this, just to make this very clear, not only are there very good studies that have validated the effectiveness of AFOs like the MBBs that allow normal range of motion, these devices do not make the ankle stiff. They're not for that. If anything, they're a posterior release style that helps lift the foot up, but they do not make the ankle stiff. And they're lightweight and they're easy and they go into a shoe easy. But what we're trying to do simply with the brace is address and modify abnormal biomechanical things happening in the feet that can lead to a fall. That's all we're doing. And so when you look at the risk factors for falling, muscle weakness, gait abnormalities, mechanical issues like we've talked about, again, slow gait, ataxic gait, all of those are addressed through orthosis. And what we're using is a orthosis that has an ankle component.
Yeah, agreed. It can be very significant. And I know, you guys have both addressed it, but I want to make it clear to any physicians out there that do feel like they would like to pursue these options, but they're uncomfortable having these conversations. There is a little salesmanship involved. You don't want to scare your patients. You don't want them to make them think that you're putting them in large, cumbersome bracing and those type of things. So medical devices, excellent term. And then also reach out, talk to Dr. Moore, talk to Dr. Ripp, get the verbiage down, practice it a little. There's an art to it. You're not going to be great at it the very first time you do it, and that's okay. But these patients just want help. Whether they know it or not, they want help, they need help, and that's your job to do that. Take one little step back. How are you identifying your patients that you're assessing? And then once you've done the interventions, such as physical therapy, a more balanced brace, I think Dr. Ripp, you had mentioned you bring them back in a few months. Dr. Moore, how often do you bring your patients back?
The 97750 code, which is the code we're using to do this test. I think there needs to be some level of caution in that it's a functional assessment with a treatment plan that you're putting in place. You have to have those components. So although the LCD for this code does not specify an exact number, it has to be a reasonable number. And when you repeat it, there needs to be something that's altered or changed with the patient that would necessitate medically the performance of another 97750 code. So for me, that is really simple. If the patients have had a fall, a trip, or if they have gone from walking to a cane or to a walker, and there's been a pretty dramatic change in their mechanics, that is the indication that I need to do an assessment. And so in my mind, if you have a very high-risk patient that is where there's constant changes that are going on, and they may have already received the braces, they may have already had treatment, but if those patients are really high risk, there's no reason that you shouldn't have those patients come in and have them checked and do the test. But I would say that to bill the test, there needs to be medical information in the note to necessitate the need for a further test. And so for me, for my high-risk patients, I would say sometimes that can be 3 or 4 times a year because those patients are coming in with constant need for reassessment because they've had an event. For some people, it's once a year, but that has to be based upon their risk, and it has to be based upon your documentation for what event has changed your plan that you put in place when you did the 97750 to begin with. Maybe hospitalization from a fall, maybe a hip fracture. That's clear indication to do the test again. I would just relate some degree of caution and make sure you document well the reason why you're doing the 97750 code.
Dr. Ripp, what is your approach? How often are you assessing your patients? How do you approach this?
I'm looking at the age, obviously the factor, right? Are they 65 years and older? Looking at the CDC recommendation and guidelines for fall risk, looking at their subjective complaints, and are they using a walker? Are they using a cane? Similar to things that John just said. Generally speaking, if they failed the fall risk and I put in a therapeutic plan into place, I will redo the fall risk 3 months after the fact. So failed study with a plan in place, 3 months. If they fail the study and I do nothing with it, which hopefully I don't do that, I'm not rechecking them. If we do the fall risk and there's a low fall risk or no fall risk, really, if there's no fall risk, I'm not rechecking them. So really it's the individuals, and I would say max that I'm probably doing is twice a year. So I'm probably maybe underdoing it compared to John. So probably twice a year I'm doing the fall risk assessment. So that's kind of where I sit. One of the things that I do it on that a lot of people may not think about is I actually do a decent amount of total ankle replacements. I do a decent amount of big rear foot and ankle reconstructive surgery. It's not uncommon for me to do it on the pre-op visit, and then it's not uncommon for me to do it 3 months after the surgery. To
That makes all the
see,
sense in the world. Yeah.
yeah. So I do it on a lot of pre-ops and a lot of post-ops purely for, hey, is the surgery working, right? Is their balance improved? Are they happy? And so I actually would encourage, if they're doing deformity correction, let's put it that way. If you're doing deformity correction in the foot, absolutely you should probably doing it before, and you should be doing it 3 months after the fact when they're back weight bearing in a regular shoe to see where are they and what else is needed. A lot of times they still have strength loss. They need continued physical therapy at that point. And so I just think that's a thinking outside the box rather than just, the geriatric population that's at risk for falls. You can do it on your 40 and 50-year-olds. You can do it on your 55-year-olds. It's not limited to just our geriatric populations, but I would limit it to those individuals where they have such deformity that require surgery, and we're doing kind of a pre and a post analysis.
If your interventions have worked and you've really reduced that risk and you feel like that patient is much safer, great. That may be all they need for that year. If that patient is still a work in progress, right, you're still putting in new interventions, you need to continue to assess if those interventions are working for those patients. I think this is a great way to do it.
And I'll also add to that too,
Sure.
we talk about the code 97750, right? And that's that therapeutic plan of action code. Going to John's point, let's say that there's a reason to do it, but maybe he's not billing the code.
Mhm.
If you look at our E&M coding and you look at our complexity of coding and you look at the time it takes to do the analysis and the test, realistically, you probably just improved your E&M visit from a level 3 to a 4. And so in those cases, and I'm not, telling people, oh, do 4s with everyone, if it warrants it, which based on time alone, in a lot of cases, this will warrant it. If you don't build a forest, you can actually utilize this test to get to a higher level E&M code. And so going back to what John said, right, there's substantial revenue that's we can identify with falls, right? E&M coding, we could do the 97750. There's orthotics, there's ankle braces, there's night splints, there's custom AFOs, there's referrals to our PT colleagues. You're going to refer them business. They're going to refer business back to you. So all of this is a part of this. So that's another thing is going to that point. If you're like, well, or maybe it's a payer that doesn't pay for a 97750. They all pay for that higher level E&M coding. So something to think about. I utilize that in my practice. Once again, it all falls with documentation, and documentation is key for the 97750. Documentation is key for that higher level E&M coding.
Dr. Moore, do you want to talk a little bit about how you're doing that, the medical justification for a more balanced brace, and how you document that within your practice?
Yeah, that's a great question. I mean, you have to have one of several different diagnoses, the chief of which is muscle weakness. That's the key indication for the balance AFO, or for any AFO for that matter. You have to document muscle weakness. So when you do the safe balance test and you're documenting a failed up get up and go test, or you're indicating somewhere there's abnormal muscle tone or muscle weakness, that is a clear indication opening a pathway for the use of an AFO. The number two is some type of orthopedic condition. And that orthopedic condition obviously can be muscle weakness. It can be a tendon issue. That is a musculoskeletal underlying condition that requires a device that is custom. The other thing that you may have, and again, it's obviously documenting abnormal gait, and that that with the AFO, you're attempting to try to correct those abnormalities. I would be careful though for AFOs, there has to be some underlying documentation of muscle weakness or some orthopedic condition that necessitates a customized device that's intended to be used for 5 years. So the safe balance is a beautiful way of getting that going, but that should not be used alone as the indication for AFOs.
I want to add something to what John said, and this will give you guys an insight to how my weird brain works. Okay. But when we think about safe balance and doing the fall risk, and we think about AFOs, right? I'm going to talk about Costco. All right. And you're like, what does Costco have to do with this? Okay. I'm a believer. If you go to Costco and you leave without getting a hot dog or a slice of pizza, you just committed a sin. Okay. So that is how Gavin Ripp works. But the reality is, if we think about that, Costco's not making money on the hot dogs. Costco's not making money on the cheap slice of pizza. They're not even making money at all on their concessions. Maybe a little bit, probably not a lot. Why do they offer it? They offer it because when's the last time you've gone to Costco and you walked out of there with less than $200 in purchases? Just doesn't happen. Okay. So for me, what does that mean? Why are we talking, Gavin? Why did you even bring that up? Right. The fall risk to me is the hot dog. The fall risk is to get your patients into the door. The balance brace is now the supply. This is where the return on our investment is. This is actually economically favorable to us. This is where there's actually big returns, but we use the fall risk. We use the therapeutic plan of exercise for comprehensive care, but it also actually, from a revenue perspective, it leads us to the balance braces. A pivotal part of someone with a large fall risk is getting them into more balance braces. Mm-hmm. And the more balance braces in a well-fitted shoe is one of the best things we can do to improve their balance.
What I think is imperative for the doctors to understand is that when we treat at-risk patients for falling, that we are not approaching this as a one treatment fits all. So I think that if the patients perceive that all we're doing is trying to get a brace on them, it's going to seem insincere. It's going to seem flawed. But in the presentation, it has to be packaged and presented as a algorithm, as a plan, not just a brace. I think that there was a time, maybe early on, where doctors were going in and really pressing so hard on the brace that it looked as though that they were not doing anything else. But to really do a good job addressing fall risk, we need to be looking at all these other things. I would hate for anyone to present the more balanced brace as this golden ticket or that's it's done in isolation. I think that takes practice, and I think we can get our doctors to do better at presenting that.
A lot of times it's the beginning of a long-term conversation, right? You introduce them the brace, you show them the brace. Maybe if they're not quite ready for that yet mentally, it may take them a few appointments to get there. It may take them another small event to get there.
That's right.
You've shown them there are options. They're going to be thinking about it when they leave that exam room, when they go home that afternoon. The next time they stumble, they're going to remember you speaking with them about that brace. So I think oftentimes they come back and they will start the conversation back with you, even if they don't go, even if they're not interested the very first day. Have you seen that, Dr. Moore?
100%. I think you've maybe even seen that in my clinic where it's the third or fourth visit and they say, yeah, I mean, nothing I'm doing is helping. Or it's the point at which I tell them you're gambling by not doing something. But I will tell you this too, and I've said this before, and this is something that in my clinic, it has been essential. And that is for the patients to have something that looks professional with the MBB on it, whether that's a poster or brochure. What that does in their minds, it validates it. If you're trying to describe it or telling them that, oh, we're going to put this brace on you, and you don't either have it or you don't have a picture of it, or you don't have anything that's written on it, that is a huge leap for a patient to make. In fact, I think it's an insurmountable leap in some situations. So I highly recommend that there be something in the clinics where the patients have with either a picture of it with some information on it, even if it's just a flyer or a poster, something that says, oh, we use this. This is part of our plan. This is part of our algorithm. So it doesn't look like you're kind of riffing.
And going back to what Jonathan said, like it's a very important tool, but so is the physical therapy and the strength and the rehab. Right. So is the shoe. So is, occasionally, so is just the general night splint. Occasionally, so is just the generalized custom orthotic. Occasionally, so it is a surgical correction to fix a deformity. These are all tools that we have in our bag to improve our balance. But right. The main thing is we have to seek it out and we have to test the patients. And we have to look to identify it. They're not always going to tell you. And I think that's the most important thing. Kids, I'm fortunate enough, I treat kids and I treat adults. The single biggest indication of a kid's in pain is, are they active? Are they out there in the football field running around and playing tag? Are they being a kid? If they're sitting there on the sidelines, realistically, something's probably hurting. Adults aren't going to come to you and say, hey, by the way, I'm falling a lot. Can you help me with falls? You have to seek it out. You have to test it. You have to, quote unquote, see if they're sitting on the sidelines. And then you got to go in and fix it and treat it. And so that's my biggest thing. Great. We have tools. There's different options. There's not the same tools used for every patient. We want to make sure we're offering different types of treatments for these conditions. We want to make sure we're doing it where it's indicated, because I will tell you, our documentation needs to be good. We need to do it for the right reasons because this is a big boy game and audits are high.
Well, I think to kind of summarize as we're winding down here, Safe Balance is an excellent tool in the bag to assess these patients, to identify their needs, to boost your ancillaries, whatever they may be in your clinics. They can lead to lots of different treatment algorithms depending on the different patients and what their needs are. The more balanced brace being one of the key ones and one of the highest revenue generators. Anything else that either one of you would like to add?
I think that to get this rolling and really successful in every clinic, there needs to be kind of a needs assessment for each clinic because no clinic is alike. The key is identifying where those challenges are because each clinic has them. And maybe it's a doctor, or maybe it's a staff member, maybe it's an equipment, or maybe it's even a lack of some of these things we've mentioned, like a lack of a sample of the MBB or a brochure or a poster. I think those little things a slight adjustment at each of those clinics can make a huge difference in terms of flow. I will tell you that I've really been privileged to use the Safe Balance, and it has opened up so many doors. And having used a lot of the tools that we're talking about pre-Safe Balance, using Safe Balance and having that tool really helps validate my treatments that I was already using and enhance them.
Yeah, let me just say one thing. And I was an early adopter of Safe Balance, and I was probably one of the first in California to get it going. What I'll say about Safe Balance is you're getting a team of support behind you. And I think that's important, right? So not only do you have the program, but I will say that the Safe Balance team is dedicated to improving your practice and to help you as a clinician to provide comprehensive care. And so, a lot of us work with vendors, a lot of us work with different vendors, and we all have vendors that we love and vendors that we hate, right? And some vendors that you just have to use, right? And in this particular case, we're lucky that, the vendors really here are our team, and they're actually trying to help you and support you in your practice. And so for me, who's an early adopter, who's seen every iteration of Safe Balance almost since its existence, it's been a big lift to me. It's been a big lift to my own private practice. It's been a big lift to Balance Health. They're equally as dedicated to seeing you succeed as their patients. And so I just want to say for me, thank you to Safe Balance. It's more than just a program on an iPad. So I just want to throw it out there.
Well, we're fortunate to get to work with such wonderful providers and who are so dedicated to their patients. So we feel quite lucky as well.